The presentation is on neuromuscular taping. Neuromuscular taping is a specific method of applying a tape, which I created in the year 2000 to 2003 in Rome, Italy. Neuromuscular taping, we classify it as an elastic decompression method. We're applying an elastic tape on the skin, but our objective is to create a decompression action, a decompression force, which is obviously going to reduce underlying compression and to facilitate movement of blood, lymphatic fluid, reduce the mechanical forces over proprioceptor receptors, mechanoreceptors and pain receptors. So consequently, it has a huge impact on pain reduction and on improving lymphatic flow, lymphatic functioning, and blood flow oxygenation to a treatment area. You need 1 day, 8 hours, just to learn how to not stretch a tape. And because that is key to us to create that mechanical eccentric force, which is obviously opposed to a concentric mechanical force when a tape is stretched or we have a bandage or a kinesio taping. It has always a stretch applied to the tape. Consequently, if we talk about decompression, we can use another term to describe it by creating negative pressure. Neuromuscular taping creates negative pressure. And so this negative pressure is activated by the body movement or by activation, our manual activation of the tape, which creates this decompression and return of the tape, decompression, return, decompression, return. Obviously, as you see here, the tape is in a longitudinal direction, and the tape is wrinkling. Rhomboid, superior trapezius, neck applications, all decompression applications. It's not foreseen to apply the taping compression over these muscle fiber because, as we know, our patients are suffering because these muscle areas are suffering because they are excessively contracted. Neuromuscular taping follows the same principles. You apply the tape proximal to the area, following the lymphatic anatomy to reduce that pressure, creating negative pressure over lymphatic nodes and lymphatic vessels, and also applying the tape locally. Okay. These are applications which have more vascular objective, so consequently it can be used to treat wounds or pressure ulcers or after skin grafting or skin superficial related problems. So obviously they're being applied over areas where we have hyper or hyposensitivity, for example, scars or amputation in the case on the left side, or around the orbicularis of the mouth when we have chalaria, when we have drooling or swallowing difficulties in CP patient or in stroke patient, or again central nervous system problems, or we're applying the tape over the hand to encourage sensory feedback and afference from the hand towards the central nervous system, for example. These are more nerve, directly on the nerve applications, and so the width of the tape obviously is variable depending upon the depth of the facial nerve for the Bell's palsy, or the sciatic nerve, which is obviously more deeper, or over the dorsal spine area due to trauma, surgery, scarring, which obviously creates compression over a nerve. And so neuromuscular taping therapeutic objective is to create that decompression. So If we want, we can stretch a tape. If we don't want, we don't stretch a tape. So the tape is the same in both situations. But depends upon our manual way of applying the tape. We stretch it or we don't stretch it. We apply it in a certain way to create an eccentric stimulation or a concentric stimulation. But in rehabilitation therapy, we can say that approximately 99% of the applications are going to be decompression to encourage that oxygenation, that blood flow towards a traumatized area or to a muscle fatigued area to encourage its function and how the muscle is going to respond. Let's see. Okay. This is a treatment for Parkinson's. So this is immediately before, immediately after. And so also here you see the tape applied gives an immediate result in this case. And this is obviously just before and just after. So it's a question of 5 minutes, which is passed between before and after the application. So you see the freezing of the hand, the reduced coordination, the skin which is shiny, and this is immediately after. Okay, so it's a question of just a few minutes between one film and the opposite. And so you see a completely modified hand with improved mobility and so consequently improved stability. The objective of this course is to give you the manual skills to treat anything which comes in front of you. Parkinson's patient, ankle post-trauma edema, neurological edema in the hand, for example, functional knee.
Thank you, David. Thank you for that very visual presentation. It's great to see the cases that you've given us there, and it gives us a very good idea of particularly those videos of the immediate results. And sometimes that was something that was difficult for me to kind of understand myself until I saw it in the classroom, just how immediate the effects are in the increasing of the coordination and the mobility.